Hello, my name's Florence. Welcome to theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 54, Environment. Today is an episode with a bit of a difference. When I was reflecting on my first year of the theobspod and asking for some suggestions from my listeners, one of them got in touch, Margaret, and asked me what I thought about the book Reclaiming Childbirth as a Rite of Passage by Rachel Reed, and in particular, how to rehumanise institutional birth, especially the physical environment. Margaret asked, why are birth centres women-friendly and labour wards are not? Therefore, today is a bit of a departure. I even thought about calling the episode Bookshelf and wondered whether I might do a series within my podcast of books that I've read or that I've found particularly inspiring. I got the book, I've read the book, and yes, today I am going to talk about the book and the impact it had on me and a bit about what it contains, as well as attempt to answer Margaret's question and explore the birth environment a bit. I'd particularly like to know whether this format, as an episode every once in a while, discussing a book, would be something you'd like me to do more of in the future. And if so, what particular books you'd suggest I read. But let's leave that to one side for the moment and talk about reclaiming childbirth as a rite of passage. I wasn't sure what to expect reading the book. And it's certainly not a book that I imagine many obstetricians have read. It felt very much focused on midwifery, but it is essentially a very woman-centred book. I found it fascinating, and I'm careful about using that word because I didn't enjoy it. And I didn't enjoy it because of the fact that it made me feel extremely uncomfortable. Uncomfortable about the environment in which I work every day. It made me see that there's so much wrong that we are doing, that by the end of reading the book, although I found it completely brilliant, I also found it totally overwhelming. When I paused to think about how I might talk about the book, I really struggled. So I looked up Rachel Reed. And it turns out, not that surprisingly, that Rachel Reed has her own podcast. Her podcast is called The Midwife's Cauldron and is run jointly with Katie James. Having finished the book, I then listened to a couple of episodes on The Midwife's Cauldron about how to work within the system. And I actually found that a very helpful companion to the book, talking about many of the difficult issues that were swirling around my head. Right, enough of that. Let's turn to the book itself and the environment. The book is a combination of history, or actually she calls it herstory, her story, history of birth, some of the science explaining how birth happens and the body's response to it, the woman's response, and experiences of birth. And the book aims to provide a holistic evidence-based framework for understanding birth. The author, Rachel Reed, specifically talks about the fact that she is talking about spontaneous birth, birth without intervention, non-medicalised birth, and that in the modern age, this is actually quite rare. And I think it's important to understand that context. And me reading it as an obstetrician, as I work in a medicalised environment with women with complications, that inevitably some of the views are one end of a spectrum. And as I've mentioned in my podcast before, there's always a tension between intervention that may be beneficial to the health of the mother and the baby versus leaving nature to do its thing and what it's designed to do, and finding the right balance between the two. The book talks about rites of passage versus rites of protection. Rites of protection are rituals and rites that we healthcare professionals perform, telling ourselves we're doing it for the right reasons, such as monitoring the baby's heartbeat, but essentially which are not evidence-based and are as much cultural or habitual as they are anything else. But we perhaps dress them up as being medical. Rites of passage, in contrast, are things that a woman would do physiologically left to her own devices. And in the book, there are 5 stages of birth. And at each one, the author examines the rites of passage and the rites of protection. And I can't possibly explore the whole book here today, but I am going to think a little bit about some of these issues and perhaps what is my role in each one. The first stage, not surprisingly, is called preparation. In preparation, rites of passage are cultivating self-trust. The woman cultivating trust in herself, her ability to give birth to her baby. Modern equivalents of this might be antenatal classes, hypnobirthing, choosing her place of birth, preparing herself for motherhood, perhaps talking to friends and family who also have been through birth. Rites of protection, this is the major thing that made me uncomfortable. The author talked about us grooming compliance of the woman through antenatal care. Every appointment, every checkup on her pregnancy, every risk stratification we do, every hoop we get the woman to jump through, being grooming compliance. And I think this is why I would say I didn't enjoy the book. The idea that I spend each and every day grooming compliance made me feel rather nauseated. It's not an easy thing to reflect on. I mean to do the right thing. I mean to keep mothers and babies safe. But I could see her point. Grooming is a word with some very negative connotations, and guidelines are there for several reasons, I guess, realistically. Guidelines are there because there's some evidence and we believe that that will keep mothers and babies safe. guidance is there to help us try and provide a standard level of care to all women, so that hopefully the care you receive doesn't differ with where you live or which doctor or midwife you see. But in the UK also, guidance and care is determined by the constraints of a national health service, a system which aims to provide free care to a population, which inevitably leads to some balance as to what is funded and what isn't funded, and what is realistically achievable within a system that is trying to balance up the health needs of a population. So guidance also comes into managing the capacity of our service, how many women we can see for antenatal care, and how best we might deliver that care on a population basis. The National Maternity Review has, in fact, made a lot of effort to try and achieve safe and personalised care for women. But this is a difficult aim within a system that is simply not designed that way at this point in time. The other way in which we disrupt this preparation is what she called coaxing into labour. So induction, the idea that the woman's body cannot be trusted with her own baby. Her body is now deemed unsafe for her baby. Maybe because the baby's moving less, or we're worried about the growth of the baby. We're not trusting her body to know when to go into labour. We're inducing her. And as I mentioned in my episode on induction, that can be up to 30% of women in the UK at the moment. And yes, there has been an improvement in stillbirth rates and neonatal death rates. But at what point does the balance tip if we're making women lack confidence in their own body and their own ability to give birth? The next stage is separation. The rites of passage in separation are settling in, minimising distraction. So a woman might take herself off to a dark, quiet space with her female friends and relations, much as a mammal does. The rites of protection at this point are gatekeeping the birthing space, and interruption, and gatekeeping who's with her. And then we're surprised when labour goes off the boil. This is where I think we can have a big impact. Rather than telling a woman she's in early labour, or that she doesn't need admitting because she doesn't need pain relief, we could be much more accommodating. If the woman has contacted us and feels she needs to be in hospital, if she's chosen a hospital birth, then who are we to question that and deter her? Likewise, if she's feeling comfortable at home, who are we to say she needs to come in? Environmentally, it's true. Margaret's question is correct. Birth centres are very often much more women-friendly. They have birthing pools. They often have dimmed lights, nice decor, maybe murals of flowers or trees, and perhaps aromatherapy. In contrast, on the main labour ward, we have medical equipment. We have a resuscitaire, a piece of equipment for helping give the baby oxygen and keeping it warm if it needs resuscitation. We have a bed. We have drip stands. We have fetal heartbeat monitors. It's very different. let's think about the bed for a moment. Bed or no bed? That's the question. And in the book, Rachel examines the fact that if you have a bed in the room, a woman will end up being on the bed. Not because she doesn't know that that's not necessarily the best thing to do, but she's been culturally programmed from what she's seen, perhaps in television programmes or in films. If a bed is there, the woman will get on the bed. But when we take the bed away, it makes staff very uncomfortable. We've recently taken our beds away from our birth centre, our midwifery-led unit. And this has caused consternation. How are we going to safely transfer a woman? How are we going to suture and stitch a woman? What do we do if she has a hemorrhage? And some of these complaints and worries we may position as, but the women want a bed, rather than examining our own issues and why it makes us feel fearful. We're not used to practicing without a bed. In labour ward, we have a bed. I spend my entire time on ward rounds telling women to get off the bed. We may push the bed to the side of the room. We may try not to make it centre stage. But the practicality is that that is often where the woman will end up. We need to be more imaginative about how we use the bed. There are lots of different positions one can use in labour. Using the bed right up high for the woman to lean on, just leaning her chest and upper body on it, or making it into a chair or throne, or adding a bar when we're in second stage and the woman's pushing instinctively with her body. Come to think of it, why do we have a bed on labour ward? During COVID first wave, for a short period of time, our birth centre was shut. And we made some birth centre rooms on our obstetric labour ward. And those rooms, we took out the bed. And I took some photos because we made those labour rooms look so homely and so comfortable and so nice, just the same as the birth centre. Why is it when the birth centre reopened that we put the bed back in there? Why do we need a bed? We can monitor the baby's heartbeat, we can monitor the woman, we can do medical tests and procedures that we need or give drugs that are required without a bed. So why a bed? Is it so we can perform assisted vaginal birth more easily? Is it because women on the obstetric unit are more likely to have an epidural, and if you have an epidural, your legs become numb over time? Or is it that women have an epidural because they're in the bed? A bit of a chicken and egg, which came first, the bed or the epidural? Epidural or bed? Or do we have a bed because transfer to theatre is easier? If we're going to do an emergency caesarean section? When did a bed become a cultural norm? In the book, she talks about other trends and cultural norms, such as birthing stools or rebozo scarves. Certainly, we had a birthing rope hanging from the ceiling in one of our birth centre rooms, and it was very rarely used. And I don't necessarily think it was that women didn't want to use it. I think it was more that women didn't know how to use it, and the midwives didn't know how to use it. So it remained unused or used very rarely. when a woman was coming in labour and the midwives had a choice about which room she was going to go into, depending on which ones were free, they would avoid that room. I don't even know that the woman was asked. She might have been asked, do you want a pool or not a pool? But she was probably never even asked about anything else. Perhaps we've lost that intergenerational knowledge. In the book, Rachel talks about the gossips, and I absolutely loved her description of them. The women that are coming to the birth to support the woman, not as midwives, but just as friends and family, and gossips, local women gathering around, looking after that woman, and perhaps performing a much wider role, cooking her food, perhaps caring for some of the other children, and, as the name suggests, having a really good gossip. And the gossips would stay well into the postnatal period to look after that woman as she absorbed and recovered from her birth. We're not helping our friends and sisters and daughters give birth anymore. So it's no wonder that the cultural things we see on television or films influence us rather than the reality of birth. I think it's even worse at the moment. COVID has restricted us to single birth partners. So those women that may have chosen to have their partner and their mother or their sister are now only choosing a partner. So during separation, we're not only gatekeeping the women. Do you need admission or not? Do you need pain relief or not? But also whom the woman wants with her. I know women who've chosen a home birth purely because they want their other children to be with her. And then, worse, we start to judge what is and isn't appropriate. Is it appropriate to have a child present at a birth? At what age does it become appropriate? Do they need to be over 16? Do we need to protect them from birth, as it were? And certainly there was an outcry. I remember when Jamie Oliver and Jules, his wife, chose to have their children at their home birth. Why is that we see birth and presence at birth being so unacceptable, X-rated? We must remember that the physical environment is not just visual. We need to think about all 5 senses: smell, taste, sound, touch and sight. Touch, massage perhaps, certainly warm water in the birthing pool. And I remember when me and the delivery suite matron were radical enough that we were buying a new birth pool and we chose to put it on our obstetric labour ward. There's no reason why women who have risk factors or increased chances of something more complicated happening should not have access to a water birth. But I know we're rare in having that available. And it is only a single pool. Why should a woman be penalised and not be able to have a water birth because she happens to have a diagnosis of diabetes? It's just not fair. Smell, I've mentioned aromatherapy, but also let's think about the clinical smells. Disinfectant, blood. There are all sorts of different smells in a birthing room. How can we think about making that more homely? I don't think we've even thought about it. Do we tell a woman to bring in her own towel, pillow, things that might smell familiar and comforting? I think there's lots of room for thought there. I'm very lucky. We always felt delivery suite was a bit the poor relation. One of my obstetric colleagues did a large amount of fundraising and we bought some murals to put on the walls in our birth rooms. So we have a room with poppies all over the wall. We have a room with lavender. The environment is much nicer. It's just a much more pleasant thing to look at. And certainly this has become quite trendy in recent years. And you can see social media is peppered with different looks of how your birth environment looks. But we need to think not just about the rooms themselves, but what are the signs we have at our entrance? If a double door on the way to delivery suite says no entry, what sort of impression does that give to people as they come in? We have a doorbell that needs to be rung out of hours. And I usually explain to women, don't worry, it's manned 24 hours. There'll be a receptionist. She'll pick up an answer and let you in. Don't be put off. But we need to welcome people in. And that's why 15 Steps is such a good initiative. Thinking about viewing with fresh eyes what it's like to walk in, perhaps from the car park or the train station. I noticed it during COVID. There was a sign on our birth centre saying strictly no entry. It was a new sign. It made some of us feel unwelcome, uncomfortable. We stopped walking through and saying hello to the staff on duty. We felt a little rejected and sad that we weren't welcome anymore. But when we had a conversation about it, it was just because of infection control. It wasn't aimed at us. It was aimed at birth partners who were coming through from the postnatal ward by accident. But again, we had to think about that sign and the unexpected consequences. So there's lots to think about in terms of environment and separation. Then we have liminality. This is a word I wasn't really familiar with. And then obviously she talked about subliminal. And subliminal I was aware of. So liminality is about withdrawing into unconsciousness, by which I mean conscious thinking. The rites of passage are being betwixt and between, in on herself, focused on what her body's doing, giving birth. And our rites of protection might be counting heartbeats, plotting progress. What's my role in this? I think back to my podcast on vaginal examinations, it might be leaving women longer in between examinations, thinking about what's really necessary, what there is to be gained, encouraging midwives to go with some of their other skills, looking at how the woman's behaving, encouraging intermittent auscultation rather than continuous monitoring where it's possible, and not putting that time pressure on women, not setting limits, but trying to go with when does this woman feel comfortable with what's happening to her and when doesn't she? Being there for that woman, but not interrupting. And I think sound is a big issue in hospital. You've got buzzers going, just normal call bells, emergency bleeps, cleaners polishing the floor, pharmacy deliveries, equipment deliveries, emptying the rubbish. I find it myself when I'm doing a ward round. Sometimes I can hardly think for the amount of background noise, chatter of different members of staff, the phones ringing. There's an unbelievable amount of noise. And definitely when I attended a home birth, that was the big contrast for me. The quiet, the calm, and the lack of interruption. Maybe a simple thing would be to suggest every woman brings headphones or brings earplugs with her into the birthing room. But it's also about us being much more sensitive about the noises that are going on outside the room. Because a woman goes betwixt and between, I have witnessed that some women will say, "We had no idea you were so busy. We had no idea so many babies were being born that day. We never could have told. It was so calm." And I think that's because the woman is in on herself, focused on what she's doing, without distraction. The next stage talked about is emergence. The rites of passage here are affirming instinct, working with the birth dance, working with her body. And I've certainly seen this to amazing effect, particularly with the physiological breech births that I've witnessed. And I definitely think we could do much more in terms of working with instinct with babies that are head down. In emergence, this is where the woman then comes out of herself, reconnects with the external world. This can often be a moment where women feel they can't do it. They lose it. They suddenly ask for an epidural or get distressed, lose their self-belief. They literally emerge back into the room. And that's where we as professionals need to work on affirming that she can, that she's got this far, that her baby's about to arrive, and that she is doing it, and she's doing fine, and we're there to support her, but she needs to go with the work her body's doing. And I think that's sometimes where things go a little bit awry. A woman asks for an epidural. A midwife might feel, yes, I've got to get her an epidural, because if she doesn't get an epidural, she might complain. The anaesthetist comes in. The anaesthetist obviously feels one shouldn't deny a woman pain relief. And of course, if a woman's asking for an epidural, you have to listen to what she's asking, but you also have to recognise why she's asking. And it's often because she's imminently about to give birth and she's just having that briefest of crisis of confidence in her ability to do it and see it through. And actually what we need to do is go back to that self-trust and remind her that she can do it and will do it and it's okay. So emergence can take a bit of work, and we as health professionals can really influence the outcome of how that woman feels about that and that powerful urge she has and that crisis of confidence and how we help her through it. Pushing when she wants to push, not pushing when she doesn't want to push, not telling her she can't push when there's a rim of cervix left. If she needs to push because her baby's hit her pelvic floor, then actually she needs to push. It becomes more complicated if you introduce epidural into the mix, because that removes that instinctive working, that mobility. And that's where directed pushing and protecting the perineum as our rights of protection end up creeping in. But sometimes midwives who are used to looking after women with an epidural and a drip perhaps end up directing pushing of a woman that hasn't got that and doesn't need it. So I can see that we interfere significantly in emergence. What's my role here might be perhaps standing back and not watching the clock, not worrying about the length of second stage, which we're having a lot of debate about at the moment at work, but thinking, is the baby's head descending? Is she likely to give birth unaided? Or is this one where actually I do need to intervene? She does need some help, or the baby does. The final part of birth talked about in the book is integration. I loved this section of the book. It talked about the rites of passage being creating a sanctuary. It talked about enchantment between the mother and the baby. This might be skin to skin, that first feeding. And it also talked about tending to the birth story, so it becomes integral into that woman's life. She can reflect, absorb, discuss, and it will become part of her. She will be a different woman on that side of the birth than she was on the other side at the beginning. And I absolutely loved that idea. I think we're not good at this. Creating a sanctuary, integrating the baby, that mother-baby dyad, and then integration to the slightly broader family, the birth partner, the siblings, and integration into then the wider circle, family and friends. In some ways, COVID may have been beneficial. There's less interruption, there's more of a sanctuary, less visitors, much more undisturbed time for mother and baby, and some partners have been able to be much more present as they work from home. But then there's been less help. Remember those gossips? They were cooking and caring for the woman, and the woman had a lying in period, a period of time where she was literally just looking after her baby and recovering her health. We rush the postnatal period. We don't provide sufficient support. And the idea of integration, I think, is something we could do a lot more about. So those are my thoughts about the book. Although I said I didn't enjoy it, I'm really glad I read it. It's given me a lot of food for thought. And I think it's a book that I will come back to again and again. And it's certainly a book that I'm planning to lend to some of my midwifery colleagues. So as usual, I'm now going to talk about the zesty bit. What can I make of all this? What is the zesty bit? I think there are two bits of zesty bit for me. First, listening to the Midwife's Cauldron podcast after reading the book was very helpful, rather than feeling completely overwhelmed that my entire job is consisting of doing totally wrong things all the time. It made it more manageable. In the episode I listened to about working in the system, they talked about what is your sphere of influence and what are your gifts. And I suppose this is where I'm at. What is my sphere of influence? It's the women I care for, the midwives I work with, the junior doctors I try and role model to, my consultant colleagues, my audience of my podcast, readers of my blogs, people who run the maternity service in my hospital, in my local maternity system, and beyond, through my work on maternity experience. So I have quite a sphere of influence, I'd like to think. What are my gifts? My gifts, I think, are being approachable and trying to communicate. And so that's what I'm trying to do today. I can do little things in my own practice to look after the women that I'm caring for and try and spread good practice and a better birthing environment where I work. And I can try and promote others to do likewise by talking about this zesty bit. But The other important aspect of working in the system they mentioned is know your limitations. You are not responsible for everything. You are not responsible for everyone. And for me, that's a very important lesson. Aside from that, my zesty bit is about noise, lack of interruption, disruption, and reducing noise costs nothing. It may be very difficult to make your obstetric unit environment look nice. It may be that you don't have money for birthing pools, murals, a lick of paint, birthing stools, but I guarantee you could think about reducing your interruptions, reducing the noise. It costs nothing. As I say this, I'm thinking not just of the obstetric unit where women are giving birth, but also postnatal. I know some wonderful music therapists at Chelsea and Westminster who've done work with us, Grace and Claire, who play music on the postnatal ward, on a keyboard, sing a song, play a violin. Imagine what that would be like, how that would help that sanctuary, that integration. Fabulous. If you're a pregnant woman giving birth, I hope this has given you some food for thought. Don't get put off. It isn't that everything is wrong. There are lots of things you can do. And the key thing I would say is trust yourself, trust your body. Try and prepare yourself. Talk to people about their birth stories. Talk to the team looking after you. Importantly, talk to your birth partner. And think about how best you might go through preparation, separation, liminality, emergence, and integration. And if you're a maternity unit and you haven't done the 15 steps, maybe get your maternity voice partnership to do the 15 steps with you, using fresh eyes to see what is the welcome like in your maternity unit, what is the environment like, what are the smells, sounds and sights, and how might you use that fresh view to think about changing things up a bit. So I hope rather than overwhelming you, this episode has inspired you. Let me know what you think. I'd love to know your thoughts, whether you've found this an interesting episode discussing a book. And if so, what other books you might like me to read and reflect on. And finally, thank you to Margaret for suggesting such an interesting book and theme to think about. I do hope you've enjoyed listening to this episode of the theobspod. Feel free to contact me on Twitter at FWMaternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues. And please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.